good afternoon, evening, morning, depending on where you are. Welcome to CVSA's July virtual presentation. Every hour counts, streamlining care for CVS attacks. Before I introduce our speaker, I want to introduce myself. My name is Debbie Conklin. If you have contacted the office in the last 5 years, you have talked to me as I've been the program director since June of 2016. My involvement with CVSA started with organizing the Run for the Bucket in Wisconsin shortly after my son's CVS diagnosis in 2005. In 2007, I joined the CVSA Board of Directors, and in 2016, I became the program director. For the duration of the presentation, you will all be muted. Please do not unmute yourself, as background noise is distracting to both the speaker and those attending. Please also do not use your own recording device during this presentation, as we are recording this for later viewing on our YouTube channel. If you have trouble with your audio, you may consider using your phone to call in instead of using your computer speaker. Today, we have 200 people registered for this event, which means we may not get to everyone's questions during the Q&A session. Please submit your questions in the chat box at any time. We will ask the questions during the time we have available. And also, please try to keep your questions on topic of the speaker's talk. And now for the main attraction. We would like to welcome Dr. Zeyad Abdulkader, I think I said that right, as this month's presenter. He also told me most people call him Dr. Z, so that is how I'm going to refer to him today. Dr. Z is a pediatric gastroenterologist with advanced training in neuro-gastroenterology and motility disorders. He has a special interest in pediatric cyclic vomiting syndrome, which he first developed during his general pediatric residency at the Cleveland Clinic. After completing both his pediatric gastroenterology fellowship and his advanced training in motility disorders at Nationwide Children's Hospital in Columbus, Ohio, Dr. Z has now returned home to practice at Sidra Hospital for women and children in the country of Qatar. Dr. Z's research interests center around pediatric CVS, including its epidemiology, diagnosis, and treatment, among other aspects. He was the first recipient of the B Li Investigator Prize in 2019, awarded to him for his research contributions, and remains active in the field with several ongoing studies and quality improvement initiatives. Thank you, Dr. Z, for being here. We are delighted to have you today.
Thank you very much for inviting me. It's an honor, and I'm just going to go ahead and share my screen. 1 second. Can everyone see my screen? Perfect. Like I said, thank you very much for inviting me. It's truly an honor to talk to all of you guys. And today we're going to talk about predictors of hospital admission for pediatric cyclic vomiting syndrome. As you can see in the heading, it says every hour counts, and I'll loop back to that and what I mean by that in just a bit. But just the disclosure, I have no disclosures. So just an introduction and an outline of our talk today. So I'm going to start off just quickly, give a brief background to what really drove the study initially and why we first designed it and moved forward with it. We're going to talk a little bit about the study, just what our objectives were, what we found, and just kind of go over the key findings and take home messages. And then just briefly finish up by talking about next steps. Where do we go from here? What further research, what future studies are needed? And as I'm sure you all know, there's quite a bit that we have yet to explore with pediatric CVS. And then we'll wrap it up again with the take-home messages, and I'd be more than happy to answer all of your questions. And please, if anyone can't hear me or things are cutting up, just drop a message on the chat, and hopefully we can get that taken care of. Okay. So just as you all know very well, with CVS attacks are challenging to diagnose, they're a challenge to treat and manage, and they oftentimes require emergency department care and hospitalization. I'm going to bring up this just quick study, which some of you may have seen before, which is a survey of emergency department use in patients with cyclic vomiting syndrome. And just to emphasize the point in the prior slide too, unfortunately with cyclic vomiting syndrome, there's still somewhat of a lack of awareness among all providers. Patients often have frustrating experiences in the emergency department. Oftentimes they may not get the treatment that they really need, or sort of in the correct order, or in the right in an expedient manner. And as you can see here in the study, some remarkable numbers, which says, for example, diagnosis not recognized by the ER, patients with established diagnosis, up to 80% of pediatric patients have care in the caregiver group, which is really quite remarkable, and just reiterates, unfortunately, the lack of awareness that exists out there with regards to cyclic vomiting syndrome. And obviously that has some downstream effects. So with that in mind, the other piece to this too was, again, as I'm sure you all know, there's significant variability among patients with CVS. We have patients who have infrequent episodes and rarely require emergency care, and others who have numerous emergency department visits, but have never been hospitalized. And there's patients, of course, on the other end of the spectrum, who have been hospitalized over 20 times. Just to reiterate, so putting it together, with CVS attacks, some patients are managed at home, and they do just fine with that. The other subset of patients require emergency care, and from there, some are obviously discharged back home, whereas others are hospitalized. And the question was, why are some hospitalized and others aren't? From anecdotally, from our experiences, it didn't always quite fit the picture, where the more severe patients, or the patients who have more involved cyclic vomiting syndrome, are the ones who are being hospitalized. So really what we were trying to answer, and what we were trying to think through, was what factors, really, what variables, if any, really, that can help us predict the need for hospitalizations for patients presenting to the ED with CVS. And the reason that's important is by identifying those predictive factors, we can be more on guard, alert, looking out for them, and be a little bit more proactive in mitigating or addressing those factors before a patient have their CVS attacks too. And that just really, putting all of these different factors together, is really what drove our study. And in simple terms, in layman's terms, really what we're trying to figure out really is, you have two patients coming to the emergency department. Why is one of them being hospitalized and one is going home? Is it something to do with their disease characteristics? Is it to do with the management that they receive? Can you guys hear me? I think I was muted for a second. Yeah, so we just wanted to really kind of home in and see if we can identify any slight differences, any nuances in either their characteristics of their attack, or in their care that they received in the emergency department, that may have made, predisposed them to being hospitalized. Sorry about that. Perfect. So what are some of the factors that we looked at? We really started with a blank canvas, but we looked at some patient level characteristics. Look at their age at the time of their emergency department visit, their gender. Was this their first time visit for a cyclic vomiting syndrome attack? Are they on a daily prophylactic medication at the time of the attack? Did they use a rescue medication prior to coming into the emergency department? We also looked at the duration of time it took from when their attack started to when they came to the ED. And we broke that up on less than 12 hours, et cetera. And I'll show you a little bit more of that when we come to the results. We looked at the duration of time from arrival to the ED to when they got their first antiemetic and their first IV normal saline bolus. And the way we did that, we just looked at the patient's registration time, so the time they arrived to the ED, and then looked at the time either the antiemetic or the fluids were administered. Again, trying to see if there's a difference between the two groups, those who are hospitalized and patients who were discharged from the emergency department. We looked at whether the number of antiemetics that they received played a role. And finally, we looked at their volume, the total volume of fluid that they received. Just to give you an idea of our sample patient and of our sample, which is really interesting on its own, but we had identified just under 220 patients with a diagnosis of CVS in our hospital. 139 met the inclusion criteria and were enrolled. And then from those 139 patients, we were able to identify 152 ED visits in the time frame that we were studying. And the remarkable piece is that out of the 152 ED visits, 94 resulted in hospital admission versus 58, which resulted in discharge. So the first part of our analysis, as I showed you earlier with all the factors, and the first part of analysis was just to look at every factor, every variable on its own. So we looked at sex, for example. Was there a difference between male patients and female patients? Then we looked at history of a prior visit for cyclic vomiting. We just looked at them independently. The ones that we did find an association with, the ones that we thought maybe there is a link, we then moved on to our second analysis where we put them all together and looked at their impact in relation to one another. Because sometimes it could be deceiving. It could seem that, for example, male patients were more likely to be hospitalized, but when we dig in a little bit more, it may be, just as an example, it may be that male patients also happen to be younger. So when we put them all together, really, we're trying to really tease out what's playing a role, what's playing the biggest role in these patients. So what you can see here, if I just go back to the univariate analysis, so this is when we looked at all the factors independently and look at their relation to hospitalization. And what you're seeing on the screen here with the red boxes, those are the factors that we found were statistically significant. Those are the ones, in other words, that we found where there was an association between the factor and whether the patients were hospitalized or discharged. And as you can see here, we found that there was a higher likelihood that males were going to be hospitalized, that younger patients were going to be hospitalized, patients who were taking on whether they're taking prophylaxis or not did also make a difference. Whether they took a rescue medication prior to coming to the ED was actually, interestingly, was not associated in our sample. It really didn't seem to play a role as to whether or not they got hospitalized. Then we can also see here is that, as I was mentioning earlier, we looked at the time taken from the start of an attack until patients actually came to the ED. And we had split up the times into 3 different groups. Those patients who presented within 12 hours, the early presenters, you could say, those who presented within 12 to 24 hours, and those who presented more than 24 hours after the start of their attack. We also looked to see if they've had a history of a prior ED visit or not. And that was actually also found, with the time to the ED presentation, we did find significant differences between the different time groups, with the later time groups of patients who presented more than 24 hours after the start of the attack being the most likely to be hospitalized. And similarly, with the history of prior ED visits, we found that those who have had a prior ED visit were also more likely to be hospitalized. There wasn't any difference that we could see in our sample with regards to how many, the number of antiemetics, different antiemetics that patients received. But we definitely saw an association between both the time taken, so after the patients arrived to the ED, how long it took in number of hours until they got their first antiemetic. Interestingly, that was not the same when it came to the fluids. We didn't really find any association with regards to when they got their fluids. That said, we looked at the volume of fluids given, and again, we did see an association here. Interestingly, it was the higher volumes, patients who received the higher volumes were more likely to be hospitalized in our sample. And of course, we always have to take these results in context and look at the bigger picture. For example, when it comes to volume of fluids received, one argument is that patients who are receiving higher volumes of fluids are also more likely to have presented more severely to the emergency department, maybe more dehydrated, for example. So we always have to kind of keep these, the bigger picture in context. And it's also the reason why we then go on and do the analysis again, but only including the factors that were associated and looking at them all in relation to one another. So what you're seeing here on the slide is that after we took those factors from the prior slide that we did find to be associated with hospitalization and put them together in a model, essentially assessing or trying to find out what their impact on the risk of patients being hospitalized when they're all together, all in relation to one another. What you're seeing in the green boxes are the factors that stood out. So you can see that male patients were significantly more likely to be hospitalized. Younger patients were more likely to be hospitalized. Patients who presented more than 24 hours after the start of their attack were more likely to be hospitalized. And the longer it took for patients to receive their first dose of an antiemetic was also, the patients who received their first antiemetic a little bit later were also more likely to be hospitalized than those who received it earlier. And if you look at the middle box there, so the beginning of the green box where my cursor is, which says OR and odds ratio, what this tells us is really the strength of the association. So you can have factors that are associated, but it's only a slight association. It doesn't have that much of an impact. So this gives us an idea of the impact of each factor on a patient's risk of being hospitalized. And so you can see here that male patients were 4 times more likely, almost just over 4 times more likely to be hospitalized. For example, time to presentation, patients who presented more than 24 hours after the start of their attack were just under 12 times more likely to be hospitalized in our sample, which is really quite a remarkable finding. And then with regards to the time to treatment with an antiemetic, again, the time taken from when patients arrived to the emergency department to when they got their first dose, we found that with every hour, there was just under about 1.7 times, patients were 1.7 times more likely to be hospitalized too. We did not find that when we looked at all these factors together, the use of a prophylactic medication was not in fact associated with the hospitalizations. Similarly with the history of the prior emergency department visits and with the volume of normal saline fluids that patients received. And that's, again, just highlights why it's important to always kind of think of for us anyway, to think of the big picture and really kind of look at all these factors in relation to one another. So just to quickly summarize some of the key findings that we're finding. So overall, nearly a quarter of all patients with CVS in our sample had presented to the ED for an attack at least once, and 2/3 resulted in inpatient hospitalization, which is really quite remarkable. And there's few disorders in the pediatric world where there's really that high, even close to that high of an admission rate for a patient presenting to the emergency department. And again, it reiterates why we absolutely need to do studies like this one and future studies really around the same topic. We found that the factors that may predict the need for hospital admissions in our sample were, as we mentioned, the male sex, younger age, the delay in the presentation after the onset of symptoms, and then the longer wait times before receiving antiemetics. And I'm not going to bore you with a lot of the numbers, but I just want to really point out that the delay in presentation to the ED following the onset of symptoms. So patients who waited for more than 24 hours, and I'm sure a lot of you have been through this, where you're not quite sure whether you should go to the emergency department, you are trying your abortive regimens at home. But at least in our study, those who waited more than 24 hours was by far the single strongest predictor of hospitalizations. They were up to 12 times, just under 12 times more likely to be hospitalized. So putting it together, really, I think the biggest the most, I think, significant finding, the take home, is that our results suggest that early presentation and intervention may actually mitigate the risk of hospital admission for pediatric patients with cyclic vomiting syndrome, which really is consistent with a lot of what we hear anecdotal in the clinic. A lot of our families are, when they're describing their attacks, some of them without even realizing, they'll say how they rush to get their medications, they rush to give it in a way they've developed a sense of what we found here is that the sooner they act, the sooner we act and the sooner we get the treatments in them, the sooner we really intervene, the better the odds are that we can abort the episode itself, the attack itself, or even just stay at home. And it's really quite a surprising, I say, at least the degree of that association definitely surprised us. But that said, our study was really only the first step. When we look at some of the factors, such as prophylactic medications, whether they use rescue medications, unfortunately, given the nature of our study, where we were looking back at all of these charts, and doing what we call a retrospective review. So looking back at charts and getting the information out of there, it limits us in the amount of detail and the amount of information that we can get. So obviously things like what medications they used at home, what kind of prophylactic medications are they on, how many rescue medications they've tried, which antiemetic and at what doses in the emergency department. There's really, we can break down a lot of the factors that we looked at into several more to really home in a little bit more on if we can identify any patterns, if we can identify anything that sticks out, similar to the delay in presentation, where that we can learn and hopefully act on. And the reason we, some ask why does this matter? Because if we identify these factors and we're aware of them, that gives us an opportunity to either on a personal level with our patients to kind of give them specific instructions, but also when we look at a bigger picture from a hospital standpoint or from the healthcare provider standpoint, it really, one of our findings was that by every hour you delay receiving treatment in the emergency department, you increase the chance that you will be hospitalized. So now obviously there's a lot of opportunity to work with that too, whether at the level of the emergency department. For example, we can set up processes or a care path of sorts for patients with cyclic vomiting syndrome so that they are seen really quickly. We can get the treatment started quickly. Or even in our discussions with our patients, knowing this information, knowing that potentially we need to act sooner can definitely be helpful for our patients too. But I think first when I look at these results and the first thought that comes to mind is we have so much that we can work with, especially in the emergency departments and with our emergency medicine physician colleagues, that by streamlining the process from when they arrive in the ED, and we can get things moving quickly. Hopefully we can send you guys, send the patients home. And let me just move on to that quickly to the next slide. So what should we advise patients to do? I think that's one of the main questions that comes out of the study is, and I've been asked this before, is, so do we tell our patients to just come to the emergency department as soon as they have an attack? And really the answer, if we go back to, to that first slide, is I think the important piece is that with cyclic vomiting, as I'm sure many of you know, it's a highly variable disease. We have patients are on such a wide spectrum that to give one message out there, just one response, doesn't really do justice for all the patients, and it doesn't necessarily apply to every patient too. So I think that the take-home message is that now that we know that, moving quickly, getting treatments in, if needed, taking to the emergency department, knowing that potentially can affect the likelihood of whether your patient is going to get hospitalized or not. That's definitely a point that we need to, as providers and you as patients, to take back to our physicians and say, so, based on our own history, based on how we, what we saw happen in our last attack or the attack before that, what's the general characteristics of your attack? And really have that discussion with the providers too. Studies like this help give us context, and can definitely serve to really, in a way, to help you ask your providers those questions themselves, like, do we need to come in quickly or not? To give a blanket statement, like I said, would not be fair, but and that's what I tell both patients and my colleagues, is that every patient's course is a little bit different. That said, as I'm sure many parents face all the time, is, do we need to bring them to the AD or not? And there's always that debate. At the same time, you're trying to give them medications, you're trying to do a million things at once too. And this message can say, hey, if you bring them to the AD, it may not be a bad decision. And we may be able to, if we can streamline their care, get them, get the treatments in them, get fluids in them, etc., we can potentially end the episode sooner and have them go home sooner. From our standpoint as healthcare providers, and also, I think one of the big pushes now, especially in the last couple of years, that we're seeing in the cyclic vomiting syndrome world is the idea of providing our patients with a template that is a general template that states their diagnosis, tells patients that they have cyclic vomiting, tells them what in the past the medications that they have received, and that's obviously tailored to every patient. And that takes both a lot of anxiety for our families away, that they have this document that they can just hand to the physicians, but also it can help avoid a lot of the misdiagnoses. It can, as I'm sure you know, a cyclic vomiting attack can look like a million different things. And for someone who, for any doctor, any healthcare provider that doesn't see cyclic vomiting frequently, there's a million different differentials, different routes that they can go down. Unfortunately, as we've learned with cyclic vomiting, is if we're delaying management, if things that we're just sort of not staying on top of it too, that can prolong the episode, potentially prolong the episode, and increase the likelihood that patients are hospitalized. Interestingly, and this is a different study that we did, similar study, but we actually looked at the predictive factors, but not in relation to whether patients were hospitalized or not from the ED, but we looked at patients who were already in the hospital for a cyclic vomiting syndrome attack. And we looked at whether any of those factors and some others that we looked at impacted how long they stayed in the hospital. Interesting thing there as well is that the delay in presenting to the AD and the delay in receiving care in the emergency department also increased the duration of stay. So the longer patients waited, the longer they ended up staying in the hospital, which is also interesting, and again supports the conclusions that we came up that we found from our study. So just to put it all together with that, so I don't keep rambling on to it. I think we have to emphasize, and it's important to emphasize, that we need to, as a healthcare provider, we need to arm our patients with everything we can give them to help streamline their care. And by that, I mean a letter, a template with specific medications that they take during an attack, potentially talking with our emergency department colleagues, discussing what quality improvement initiatives that we can potentially work on to help streamline their care. For example, when I start next week soon, one of the things I'm hoping to do myself is to have a chat with our emergency physicians and explain why patients with cyclic vomiting are not necessarily your typical vomiting patient, why it's important to expedite treatment as best as we can, and really just to increase that awareness from the medical standpoint too, and hopefully over time we can start to really we have a big opportunity here, I think, to make a difference in the care and hopefully reduce both the likelihood that patients are hospitalized, and also how long they stay in the hospital too. Cyclic vomiting syndrome is very frustrating disease, as I'm sure you all know. But we were happy to find some actionable findings here. And with that, I'm going to wrap up, and just so we can give ourselves some time for some of the questions. Thank you so much for listening today, and I hope you find it helpful. And I'd be happy to answer any questions.
Thank you so much, Dr. Z. That was very informative. And I do see some questions popping up. Feel free to continue to put them in the chat box as we start answering them. A lot of our questions are about what happens in the ER. And I know that that's not necessarily your expertise, but maybe we can at least talk about it a little bit. Can you speak to the challenge of getting the ER to treat a patient during the critical time frame, since many patients are left in the waiting room for a really long time?
That's a very important point. I'm glad you brought that up too. And that is, I'd say, one of the biggest challenges we have. And I'm sure with emergency departments, it can be very chaotic there too. So from our sample, what we have been doing, what we were doing when I was in Columbus, the first step was, and you could also do the same with, encourage your physicians to do the same, is to have the discussion with our emergency department people. Say, hey, these are patients who benefit from more expedient care. We do not want them waiting in the emergency room. They're not our typical vomiters. What we also do, what we have really have come to do more recently in Columbus, is that anytime oftentimes our patients call us to let us know that they're having an attack, and we know they're coming to the ED, then we call the emergency department ourselves and give them a heads up. Say, so-and-so is coming in, they have cyclic vomiting. They do not want to be in a room, crowded people, lots of noise, waiting for hours, and that's going to increase the chance that they're going to be in the hospital. As best as we can we get them seen, or at least get some fluids in them very quickly, or get some medication in very quickly? And they have been very receptive, and they continue to be very receptive to that. So I would encourage that's a discussion you also have with your provider. Say, hey, if we're coming to the ED, can we maybe give them a heads up? Obviously, the emergency department being the emergency department, things can get pretty chaotic, but that would be the first step. And the second step would be obviously to ask your provider for a template or a letter that states, so-and-so has this diagnosis. It is important for their treatment they receive. The sooner they get their treatments, the more likely it is that they can get better and go home. And their treatments are X, Y, and Z. Because one of the things we find is that it's not necessarily how long until they get their first treatment that can get delayed, but they may not be receiving lower doses than the patient usually need. They may have received a different antibiotics that maybe has not worked for the patient, and all those things ultimately delay care even more. So I'd say those are the two main things. One is, I would advocate that you talk to your, whenever you have an attack or the next time you see them, advocate that, if at all possible, to have a chat with the emergency department, but also ask for a letter, ask for the template too. And our colleagues in the adult world, from ANMS, the adult motility study too, have a template that all healthcare providers can look at now, which is a great template to start off. But I would say those are the two things initially that I think could be the most impactful.
I think those are both great pieces of advice. Do you have any advice for if an ER simply won't follow a care plan?
Unfortunately, we rarely, but we do see it too. So the best thing I would say I would do in those situations is, and the letter is really, that's where it comes in, is that we're giving them, as a physician, we're spelling out exactly what medications they need, et cetera, and what doses, and patients will give that to the patients. If the physicians aren't going to follow it, ultimately, we always have to kind of keep in context that the emergency department doctors are the ones who are seeing the patient too. So I would have that discussion with them. Are they thinking that there may be something else going on? Are they worried about something else? Are they just being on the safe side? Oftentimes, if the physicians are deviating from a plan that's given to them, such as with a letter, et cetera, there's a reason for that too, and they're not just dismissing it too. But obviously, if that continues to be the case, then, or if that really is what happens, the first step I think would be to communicate that to your GI provider, and then go from there too. But like I said, oftentimes ED providers, I would say, for a number of reasons, may deviate some from the plan too, and that's why I think especially with the study that with the study results that we see, maybe, and for my patients, I do include that I do in the letter itself to say that we know that for cyclic vomiting, and in this patient specifically, it's crucial that they receive treatment as fast as possible. And the longer the treatment's delayed, the more likely it is that they're going to have to be admitted to the hospital. And obviously, we don't want that outcome. And I do include that in the letter. And I also include my contact details in there. And we're always happy to discuss. I have had patients before who have requested that the ED talk to the GI folks before. I'm hoping that doesn't have to happen, but those are just some of my thoughts on that matter. It is incredibly frustrating for patients. Frustrating for us. I can't imagine how it is for patients.
Yeah, agreed. But I think those are all good pieces of advice. I think asking some questions about why they won't follow it is probably a really good place to start. Someone is asking about the use of antibiotics during attacks. Someone was put on azithromycin, and it seems to have given longer times between attacks, up to 7 months. Do you have any knowledge of that?
Just to clarify, you're saying someone who has taken erythromycin, attacks were less frequent? That's
what it sounds like, yeah.
Yeah, and obviously it's difficult to talk about a specific patient. Obviously, every patient is obviously different, but in the general sense, erythromycin is an antibiotic, but it's also used in the GI world as a motility agent, meaning it helps stimulate your stomach to squeeze more, to contract more, to get things that are in your stomach out into your intestine faster, kind of move things along too. And in some patients with cyclic vomiting, they have responded to that before, both anecdotally and in some of the literature. But there are other times too with vomiting, just patients who are coming in and with a lot of vomiting. Oftentimes, even if they don't have an disorder with emptying in their stomach works fine. By giving erythromycin, it may help facilitate that emptying too, but it's not a medication that personally that we use first line, or we really use in cyclic vomiting syndrome attacks. There are patients who we know also have something like gastroparesis, for example, that may help in those, that can absolutely help in those patients too. But it's definitely in the literature and being discussed in cyclic vomiting world. So it's not completely by any means unheard of too, but it's not usually what we include in our abortive plans.
Thank you. This question is more of a diagnosis question. Can a child be diagnosed with CVS when an attack only lasts a few hours and only needs home care? So this person, they're in the preliminary stages of diagnosis.
That's a great question, and that's a question that us in the cyclic vomiting world from the healthcare providers are actually actively trying to study at the moment. As you may or may not know, there's three different criteria that we often use to diagnose cyclic vomiting, and they come from different groups, from the GI world and neurology world, et cetera. And there are differences in the duration, how many hours qualify or make the cut for an attack. And what I say to that too is it's not one number or one criteria. It's really we have to look at everything in totality. Does the overall picture seem like a cyclic vomiting syndrome? If the patient meets a lot of the other criteria, but they're a little bit shorter than usual, we have to think of the big picture in context too. Obviously, there are exceptions to that, is when we have huge anomalies. anomalies. If a patient, for example, just vomits one time, and that's that, and then, or does it in a pattern that's really not the pattern we see with cyclic vomiting syndrome, and those are really the anomalies in the data, then I would say, well, maybe it's really something else that we really need to look at too. But I would focus more on the totality of all the criteria together, and not necessarily when it comes to hours anyway, not necessarily on whether it's 5 hours or 6 hours too, especially if they're meeting other criteria. And I know that's not a definitive answer, but hopefully over the next couple of years we can really nail down what the classic patterns are.
I think it's a good answer, though. I think that probably helps the person that asked that. Any sedation meds that you know of that people have had success with at home? This person says the 4-hour sleep is key for their daughter.
No, that's a great question. And yes, in a lot of our patients, or in a good portion of our patients, I should say, there's a couple of different settings you can use, but one that we use is Ativan or lorazepam at a low dose. And obviously those are only used for an attack. And I've had patients who only respond to something like that. But those are fewer patients. For most patients who I prescribe Ativan or lorazepam or a sedative really for, it's really as a second line or as a complementary. So either they give it at the same time, or if they've given a first medication, they've waited a little bit, things aren't exactly improving, or in the case of the person asking the question, we just know based on their history that they need to sleep, and that's the only way they can get to sleep during this attack, and the sleep will break it. Those are the subset of patients I have definitely used it on. And the other drug that we use too, it's not really classified as a sedative per se. It's Benadryl. It's an allergy medication, but it has sedative properties. And I've had a good portion of patients who really benefit from that, it also can improve the nausea feeling sometimes. So they've benefited both from the sedation standpoint, but also from the fact that it helps with your nausea too. So I would say Benadryl, which is diphenhydramine, and Ativan, which is lorazepam, would be the two sedating drugs that we'd use. And this is in the outpatient setting. Obviously in the inpatient world, it can be a little bit different too. Hope that answers your question.
Yeah, I think that does. That's great. Do you advise avoiding triggers all the time or only during sensitive periods?
That's a great question. And it goes back to the nature of what the trigger is. Exciting events, for example, is a known trigger, birthdays, holidays, etc. And you can't really avoid those. And really, rather than avoid such triggers, we have to figure out a plan around them. And I'll give you an example. I have a patient who, without fail, any event, any birthday, any party, any holiday, etc., that's always a trigger. So over time, we have come to a regimen where around such periods of time, we're a little bit more proactive in some of their medications, whether it's the rescue medications or the prophylactic medications. And simply because we know their trigger is very clear. Now, if for example, with food items, if you know that when you eat this food that you're more likely, or it's likely to trigger an episode, and again, we have to keep in context the age of the patient. We don't want to restrict patients from big food items or things like that too, but it's really a judgment call. If every time a patient is eating something or participating in a trigger, and that's causing them to go to the emergency department, then yes, in those situations, it's probably best to completely avoid those situations, completely avoid it. Keeping a diary, patients have found that really helpful. A diary of when they've been exposed to triggers, or when they've had an attack, and just jot down as many notes as possible over a course of a year or even longer. And then when you look back on it, you start to see some of the patterns are a little bit more clear, both patterns that tell you you should definitely not do this, but also patterns that say, well, maybe you could get away with this every now and then. But again, it's really dependent on how severe the trigger, or how severe the attacks are, and how much of a trigger the whatever we're talking about really is.
Great, thank you. Just a note to everyone, there's a lot of conversation going on in the chat box, which is great. I think it's awesome, and I apologize if I skip over your question. I am trying to pick up and choose the ones that are most relevant to our topic. So just want to make sure people are aware of that. Did you see any interventions in your study that helped prolong time between episodes?
That's a great question, and that's really one of the main questions in the cyclic vomiting world that we hope to answer. But in our study, we actually just looked at what happens when you have an attack. So you come in, once the attack starts, once you're in the emergency department, what's happening there, and what can we really then do to help improve that? So we didn't look at basically the frequency of episodes per se. And there have been studies in the past that have looked at that. A lot of them have also looked sort of in the rear view. But that's a great question, and absolutely one of the $1 million questions, you could say. But we didn't, not in our study. We were looking really at the time of that attack moving forward.
Great, thank you. Let's see, this person is talking about their bad experiences in the ER, and every time they have an episode, they try to re-diagnose them with CHS, even though they're diagnosed with CVS. They always treat me like a drug seeker. Do you have any suggestions?
We hear that, and I'm sorry you have to deal with that, and we do hear that quite a bit too. I would say, ultimately, if you're in the ER and you're vomiting, you're not feeling well, you'll be treated. And there are obviously differences in some of the treatments between both CHS and CVS. I would advise to really, I think in the emergency department, they just met you. They have to go by whatever numbers they see in front of them, have to make quick decisions. That's not to defend, but just the nature of the work. So I'd say the better, more likely, the more effective option would be to go back to your primary provider, explain that this is what's been happening, and then your provider can explore, is there a chance that this could be CHS? Is this really CVS? And if it's, like you're saying, in your case, it's clearly cyclic vomiting, that's where a letter can be very helpful again. And in the letter, I tailor the letters to my patients, and it's very specific for every patient. You could specifically say, in this patient, for example, we've gone through the workup, we've known this patient, they have a diagnosed cyclic vomiting syndrome. And I advocate coming at it from that end too, just because that gives you the time to have that discussion with your doctors in a more thoughtful manner, and not when you're not feeling well and in the chaos of the emergency room. But it's an unfortunate experience for a lot of our patients too.
Yes, definitely. There's no easy answer for that one. What are your thoughts on the Mito cocktail in use for CDS patients?
Yeah, that's a great question. So when we look at a lot of the supplementations that we use, and those are not really for an attack per se, like we look at the study, but more on from a prophylactic standpoint is, can we reduce the frequency of episodes too? And there have been retrospective studies, meaning studies that looked, again, in the rear view, that have shown that with some supplements, there may be a benefit. What I mean by that is it may reduce the frequency of episodes. But really, when it comes to our gold standard, meaning what we look for when we're thinking about does a medication really work or not, is to do a trial on it too. And we don't have a trial yet on a lot of those mitochondrial or just in general for supplements too. And hopefully that will be happening soon. But from our own personal experience in our group when I was at Columbus, again, it was one of those where we have patients who did not want to be taking them, We had patients who tried them and really found little benefit. And then there's patients who have actually responded very well. The difficulty with answering your question, just based on our clinical experience, is that times, I found anecdotally anyway, the patients who end up taking a lot of the supplements are the patients who are also on other prophylactic medications. They're patients who are experiencing more frequent episodes. They'll be more proactive. Cyclic vomiting syndrome is playing a big role in their lives. So, and when you're taking multiple medications, it can be more difficult to discern what's working and what's not. I would not recommend against it by any means myself, but I think we need really more studies before I can give you a firm answer on that.
I think that's a good answer. I have a lot of people in the office ask me questions like that, and I always tell them the problem is not one thing works for everyone, right? That's the biggest issue with CVS.
And unfortunately, our knowledge of CVS is gaining pace pretty rapidly, I think. But there's obviously a big gap in a lot of the research out there for cyclic vomiting, which makes patients' lives more difficult. But hopefully we'll start getting those out, and we'll have more firm answers for you.
Yes, absolutely. I'm going to ask you this question about retching, because I've had this one and I never know how to answer it. Have you ever diagnosed CVS with someone who just retches but doesn't actually vomit?
So yes, in both two types of patients, really. I've had patients who've maybe not with every single episode, but they've had episodes where it's only retching. Oftentimes they'll say, well, we haven't eaten anything, we weren't feeling great. They end up, there's nothing left that's retching, or they only bring up small amounts of fluid from their stomach. Other patients are obviously patients who have had Nissen procedures, which is a surgery where they can't really bring things up. We sort of close it off so you can't bring things up, and they end up retching more. Unfortunately, those patients, the cyclic vomiting came after the surgery, which and the retching is not pleasant. So yes, we've seen it before. That's not something that would make me think absolutely not CVS. Obviously, most patients, I would say, they do vomit, or at least start off with vomiting before it sort of transforms into retching, especially if it's a more prolonged episode.
Let's see. There's a question in here about the vagus nerve stimulator placement. It just says, have you found any assistance by a vagus nerve stimulator placement? I guess is their question.
So with the vagus nerve stimulator, I'm not sure if they're referring to a gastric pacemaker, which is a gastric stimulator. But if I take that question in terms of sort of neuromodulation, which means working with nerves like the vagus nerve, for example, or intervening with those nerves in a number of ways, whether it be a stimulator or a pacer, et cetera, there's definitely research that suggests that there's potentially a good role for that in the management of CVS. I know there's studies that are active at the moment that are looking at whether it's the different nerves in the body, but you are referring to the gastric pacemaker specifically, which is affecting your vagus nerve. We, from our experience, and we've done for a number of gastric pacers in general, that it's unlikely to happen.
I didn't get that. Could you try again?
But there's definitely neuromodulation is definitely is where a lot of the research is heading. So give us a couple of years and I'll have a better answer to. But if it's the gastric pacemaker and the gastric nerve, then from our experience anyway, we haven't really. That's not something that we have used ourselves.
Great, thank you. And a couple of our other presentations that are on our YouTube channel did address some of that stuff. So I would recommend that person that asked that question to check out those presentations as well.
With Dr. Kovacic, doing a lot of those studies. So
yeah, she did. That was her talk back in I think September of last year that talked about that. So it's a good one to watch. Let's see, any comments on daily debilitating morning nausea between the vomiting episodes?
Sorry, can you repeat that again?
Sure. Any comments on the daily morning nausea between vomiting episodes?
Yeah, so a couple of points on that. I think the main point is when we look at cyclic vomiting, one of the characteristics, the differentiating character, meaning one of the characteristics that makes patients with cyclic vomiting stand out is that they're running around, they're perfectly healthy, they're doing fine, and then all of a sudden an attack starts for however long it takes, but then almost just as quickly the episode terminates or stops, and they quickly go back to their usual health, normal health, and without any other issues. And that's if we're looking at patients with just cyclic vomiting syndrome. That's the general pattern for most patients that we see. That said, could patients have more than one thing on? Absolutely. Could the daily morning, I'm just throwing out as an example, could they have reflux? Because that could, in some patients, bring up early morning nausea, or there's a list of different diagnoses that can also cause the symptoms. So, and what I would say is that it's not necessary. I wouldn't say that because there's daily nausea that completely rules out cyclic vomiting. I think we also have to entertain the idea, could there also be something else going on in addition to the cyclic vomiting? And that's where I would go with that too. And it is, we do have other types of cyclic vomiting that we're trying to get a better understanding of, where there may be some more chronic symptoms, but that's still in the early. I think our understanding of it is still in the earlier stages too. But you could certainly still have daily nausea, and there could be other things that are going on, even if it's quote unquote benign things that are going on that may be contributing to. Having cyclic vomiting does not mean you cannot have some of those other things going on too. Does that make sense?
Yeah, thank you very much. Someone's asking about the pain. My daughter is doubled over and stabbing stomach pains during a bad episode. They say it is from vomiting, but it is a different pain.
Yeah, so I'll tell you, I'm smiling for that answer, but pain is absolutely, we can absolutely see that in attacks. And it is one of those things as well that some patients have it, others don't. And we have to look as well, are there other similar disorders that we have to think about when, especially if the pain is the main symptom? For example, things like abdominal migraines, things like a blockage in your urinary system, which is definitely more rare. But we have to, as physicians, and even as a patient, if pain is the more predominant symptom, that does not mean necessarily that this is not a cyclic vomiting syndrome attack, but it also means that we have to maybe take just a second and think, or just to make sure we're not missing anything. And like I said, in the vast majority of patients that I've seen anyway, pain is a part of their cyclic.
It's 9 o'clock.
Pain is a part of their CVS picture, and so it's what they get during an attack. But what you're saying is definitely a story I've heard before, where it seems almost like the pain is more troublesome than the nausea. Obviously, frequent emesis, even retching, that's not going to be pleasant on your stomach, and that can contribute to some of the pain as well. And I would say in patients who have pain as a main symptom, treating that pain is important during an attack as well. We tend to focus, I mean, as physicians, we tend to focus on the antibiotics, et cetera, but sometimes even treating the pain can be very effective.
Great, I think that's helpful. I think you're right. A lot of people, the pain is worse than some of the other symptoms.
Unfortunately, it's one of those things that can sometimes throw the ED off as well. They're like, well, but there's pain, it's just part of the awareness that we have to keep putting out there that yes, it can be part of it too. And it should be treated in a general sense.
Absolutely. One quick note there's some questions about asking for doctors in specific locations. Please, people that are asking that, email the office, cvsa@cvsaonline.org. We do have doctor lists that we can send you. So that'll be the easiest way to address those questions. Let's see, I think we have one last question and then we'll wrap things up today. Someone is asking, and I really actually love this question, and I would have this question myself too. Just curious and grateful that you are doing this work. But would love to know what inspired you to be interested in CVS as an area of practice and research?
Great question. It's sort of a few things happening at the same time. I don't have CVS myself. I don't really have any family members who have CVS too, but initially it started, I just remember very clearly as a first-year resident where this just incredible frustration as a physician, as a doctor, that I had this patient of mine who's 6 or however many years old, just sitting on the toilet, just miserable and for hours on end. And really it's just, and you couldn't really do anything about it. And then it's like, well, if that's how I feel, how did they feel? Can you imagine the frustration? And that was really what initially piqued my interest. And then the second piece too was, as I progressed really through residency, is it really kind of sunk in just how little information is out there, but unfortunately how often that patients aren't getting the treatments they need to get. They are delaying their treatments. It's parents and families who have children with cyclic vomiting syndrome have enough on their hands, particularly during an attack. And to add that whole different layer merged, with the whole ED and imagine with all the ED dynamics there. So, we get calls all the time when I'm on call, and it's like, well, you have to think of cyclic vomiting syndrome. So putting all those things together, I was like, well, this is, there's so much that we can potentially do. And unfortunately, patients right now are oftentimes still struggling with it too. And I'm hopeful, fingers crossed, that over the next however long, we can start to make some of those strides too. But it was just really, it's painful to watch, as I'm sure you all know very well.
Yeah. Well, on behalf of CVSA and the whole CVS community, we thank you, because we know there are not a lot of doctors that have a huge interest in CVS. Just a quick note before we end. I just want to mention that you were the recipient of the B Li Young Investigators Award, and I realize that some people probably don't really know what that is. CVSA established an award to honor Dr. B Li, who has been in the field of CVS for I don't even know how many years, very many, and seen probably about over 1,200 patients in his practice. And so CVSA established an award to honor him for young investigators, and Dr. Z had won it the first year that we collaborated with NASPGHAN to provide it. And so that's what that award is. And we are very thankful that Dr. Z is interested in CVS and is continuing to be interested in CVS. And we also thank you very much for spending your evening with us, since it's coming on about 9 o'clock, right, in Qatar. We very much appreciate that you were able to join us from around the world, pretty much.
Thank you very much for having it. It's truly an honor to talk to you guys, and for mentioning the award. If I can have a fraction of the impact that Dr. B Li has had on cyclic vomiting, I'd call that a success. But thank you so much for having me. It's truly an honor, and hopefully we can do these again.
Yes, absolutely. Thank you everyone for joining us. And again, the recording will be on our YouTube channel, and usually we have it up in about a week. So look for that in the next week or so. Everyone have a great day.
Thank you so much. Bye-bye.